Welcome to our video on blood transfusion reactions. Let's begin. Here are the topics we're going to discuss in this lecture. Let's start with allergic reaction. We're going to address the pathophysiology, clinical features, and treatment of allergic reaction. Allergic reaction occurs minutes to 2 hours during or after the transfusion. It is a type 1 hypersensitivity reaction against the plasma proteins of the donor. The clinical features of the allergic reaction include urticaria, pruritus, wheezing, and fever. Recall that urticaria is characterized by pruritic, well-circumscribed, and erythematous plaques. For the management of allergic reactions, we administer antihistamines, for example, diphenhydramine. However, if the reaction is severe, we should stop the transfusion and administer epinephrine. Let's try a question. A 35-year-old man is evaluated in the hospital for a skin rash for the past 10 minutes. He has just been involved in a motor vehicle accident causing him to lose approximately 1.5 liters of blood. He has been receiving blood transfusion for the past 30 minutes. His vital signs are now stable, and the cardiopulmonary examination is unremarkable. Physical exam reveals pruritic erythematous plaques. What is the most likely diagnosis? This man is evaluated for a skin rash for the past 10 minutes. He's been receiving blood transfusion for the past 30 minutes. His vital signs are now stable, and cardiopulmonary examination is unremarkable. These clues make anaphylaxis unlikely. The physical exam reveals pruritic erythematous plaques consistent with urticaria. Urticaria in a hemodynamically stable patient receiving blood transfusion suggests the allergic transfusion reaction. Next, we will discuss anaphylactic reaction. We're going to address the pathophysiology, clinical features, and treatment of anaphylactic reaction. The anaphylactic reaction is of sudden onset, typically within 2 hours of transfusion. It is a type 1 hypersensitivity reaction, and it is common in IgA-deficient patients who receive blood products containing IgA. The anaphylactic reactions have more severe presentation than the allergic reaction. The patient suffers difficulty in breathing, wheezing, and respiratory arrest. Hypotension and shock can be present as well. For the management, we should directly stop the transfusion and administer intramuscular epinephrine. Airway management and supportive care should be provided as well. A 34-year-old G1P1 woman is evaluated due to itchy skin rash and difficulty breathing for the past 5 minutes. She's been receiving blood transfusion due to severe postpartum hemorrhage for the past 10 minutes. Her vital signs include a blood pressure of 80/60, heart rate of 140, and respiratory rate of 25. Physical exam shows urticaria and bilateral wheezing. What is the most likely pathophysiology of this patient's current condition? This woman has been receiving blood transfusion due to severe postpartum hemorrhage for the past 10 minutes. Now she complains of itchy skin rash and difficulty breathing. Her vital signs are significant for hypotension with blood pressure of 80/60, tachycardia with heart rate of 140, and tachypnea with respiratory rate of 25. Physical examination shows urticaria and bilateral wheezing. Hypotension, urticaria, and wheezing are consistent with anaphylactic shock. Anaphylactic blood transfusion reaction is caused by proteins in donor blood that are unknown to the recipient. Initial exposure of recipient to such proteins causes sensitization by forming IgE antibodies against donor protein. The second exposure of recipient to the same protein induces the IgE-mediated mast cell degranulation and anaphylactic shock. Let's move on to febrile non-hemolytic reaction. We're going to address the pathophysiology, clinical features, and treatment of febrile non-hemolytic reaction. The onset of febrile non-hemolytic reaction is within 1 to 6 hours after transfusion. It classically is caused by leakage of cytokines from donor white blood cells after a long period of blood product storage. It can also be caused by a type 2 hypersensitivity reaction, where there is lysis of donor leukocytes by preformed recipient antibodies. The patient suffers fever, headache, flushing, chills, and rigors with malaise. For the management, we should stop the transfusion and administer acetaminophen for the fever. To prevent recurrence, we should use leuko-reduced blood products in later transfusions. A 2-year-old boy is brought to the physician for a blood transfusion session after being recently diagnosed with beta thalassemia major. Shortly after the onset of transfusion, the patient complains of chills and headache. His vital signs are significant for a temperature of 38 degrees Celsius. The physical exam reveals facial flushing. What is the most likely diagnosis? This boy with beta thalassemia major receives his first blood transfusion. Shortly after the onset of transfusion, the patient complains of chills and headache. His vital signs are significant for a low-grade fever of 38 degrees Celsius. The physical exam reveals facial flushing. Chills, headache, fever, and flushing during blood transfusion are consistent with febrile non-hemolytic transfusion reaction. Let's finally talk about the acute hemolytic transfusion reaction. We're going to address the pathophysiology, clinical features, and treatment of acute hemolytic reaction. This reaction has a rapid onset, typically within 1 hour of transfusion. It's a type 2 hypersensitivity reaction, where there is ABO blood group incompatibility that causes destruction of donor red blood cells by preformed antibodies in the recipient, leading to intravascular hemolysis. The clinical features of acute hemolytic transfusion reaction include fever, chills, burning pain at injection site, dyspnea, tachypnea, hypotension, and tachycardia. Flank pain, hemoglobinuria, and renal failure will be present as well. When we suspect presence of acute hemolytic transfusion reaction, we should immediately stop the transfusion and repeat ABO typing and cross-match testing. Diagnosis can be confirmed by positive direct Coombs test. Intravenous fluids should be administered to protect against the acute renal failure and reverse the hypotension. Cardiac function and blood pressure should be closely monitored. If hypotension is refractory to IV fluids, vasopressors are indicated. Also, if there is disseminated intravascular coagulation, we can administer fresh frozen plasma and platelets. Let's end our lecture with a board-style question. A 45-year-old man is brought to the emergency department due to severe blood loss after a recent motorcycle accident. His past medical history includes frequent childhood infections due to IgA deficiency. The patient starts receiving blood transfusion. 2 minutes later, he complains of shortness of breath and pruritus. His vital signs include a temperature of 37 degrees Celsius, blood pressure of 80/50, heart rate of 144, and respiratory rate of 25. Physical exam reveals bilateral wheezing and erythematous pruritic plaques that blanch on digital pressure. Which of the following is the best immediate treatment for this patient? A. Intravenous normal saline. B. Intravenous diphenhydramine. C. Intramuscular epinephrine. Or D. Intramuscular norepinephrine. This man with past medical history of IgA deficiency starts receiving blood transfusion after a recent motorcycle accident. 2 minutes later, he complains of shortness of breath and pruritus. His vital signs are significant for hypotension with the blood pressure of 80/50, tachycardia with heart rate of 144, and tachypnea with respiratory rate of 25. The physical exam reveals bilateral wheezing and the erythematous pruritic plaques that blanch on digital pressure. The latter finding is consistent with urticaria. All these signs suggest the anaphylactic blood transfusion reaction. The best immediate treatment for anaphylaxis due to any cause is intramuscular epinephrine. Epinephrine constricts the blood vessels and dilates the bronchi, which raise the blood pressure and relieves breathing, respectively. So the correct answer is option C. Here is a slide reminding us of the management of anaphylactic blood transfusion reaction. Let's discuss why other options are incorrect. Option A and B are incorrect because although intravenous normal saline and diphenhydramine will likely be given to this patient with anaphylaxis, neither of them is the best immediate life-saving treatment option. Finally, option D is incorrect because although norepinephrine can raise blood pressure by vasoconstriction, it will not relieve bronchoconstriction because it has no beta-2 agonist effects. And that concludes our lecture on blood transfusion reactions.